Hello everybody. Today we are going to discuss HHS guidelines which are based on the Joint British Society guidelines of for HHS. So characteristic of person with HHS is there will be hypovolemia. Then the serum osmolality will be high, that is more than or equal to 320. Then there will be the marked hyperglycemia without significant hyperketonemia, without significant acidosis, and bicarbs are always more than 50. So how to calculate serum osmolality? It is calculated by following formula like 2 into sodium plus glucose plus urea. So defining HHS by osmolarity alone is inappropriate without taking into account other clinical features. So changing the name to hyperosmolar hyperglycemic state allows for the fact that some people with the severely raised blood glucose may be mildly ketotic and acidotic. While the reason why these people do not become ketoacidotic are not fully understood. The hyperglycemia and hyperosmolality without evidence of significant dehydration are insufficient to make the diagnosis. People with HHS are generally older than those with DK. But increasingly, as the diabetes pandemic crosses the generational boundaries, it may be seen in young adults or even in children as first presentation of newly diagnosed diabetes. HHS has slower onset than the DK. This is important because the brain tissue of those who typically develop HHS, particularly in those who are older, they are at high risk injury due to rapid shift in sodium, water, and glucose. Therefore, to prevent significant neurological damage, HHS requires less aggressive fluid resuscitation and slower glucose lowering than diabetic ketoacidosis. In hyperglycemic hyperosmolar syndrome, there is usually no significant ketosis or ketonemia, although mild acidosis may accompany those affected by acute kidney injury or severe sepsis. This situation is likely to reflect a relative insulin deficiency due to beta cell exhaustion as a result of temporary glucotoxicity and excess counter-regulatory hormone production. If predominant diagnosis is unclear, early specialist input should be sought to help tailor management according to the individual's need. However, if ketone concentrations are high, then the local decay protocol may be appropriate. There remain many aspects of care that are unanswered, and the example is venous thromboembolism prophylaxis. While thrombotic complications such as myocardial infarction, stroke, and peripheral arterial thrombosis occur more frequently in HHS, it is not known whether or not this can be prevented by prophylaxis with low dose, low molecular weight heparin or antiplatelet therapy, or if full therapeutic dose should be used. So, regarding initial assessment, hyperglycemia results in osmotic diuresis and renal losses of water in excess of sodium and potassium. Fluid losses in HHS can be significant and have been estimated to be between 100 to 220 ml per kg. That is approximately 10 to 22 liter in person weighing 100 kg. So there we'll see typical fluid and electrolyte losses in HHS. So the approximately water loss is 100 to 220 ml per kg. In 60 kg individual, it is approximately 6 to 13 liter, and in 100 kg individuals, it is approximately 10 to 22 liters. Then the sodium loss is around 5 to 13 mol per kg. In 60 kg, it is 300 to 780 mol, and for 100 kg, it is 500 to 1300. For chloride, loss is 5 to 15 mol per kg. For 60 kg, it is 300 to 900, and for 100 kg, it is 500 to 1500. Potassium loss is 4 to 6 mol per kg. For 60 kg, it is 240 to 360, and for 100 kg, it is 400 to 600 mol. Now, the clinical characteristic acute cognitive impairment is not necessarily present or may be associated with dehydration, but is not specific to the condition. Alteration in the cognitive status are more common when osmolality rises above 330 mmosmol per kg. The constellation of sunken eyes, longitudinal furrows on the tongue, and the extremity weakness correlates well with the raised blood urea. Severe hypovolemia may manifest as tachycardia and hypotension. People will be identified as being at high risk by the use of validated triage system, that is NIMS. However, despite this severe electrolyte loss and total body volume depletion, often persons with the HHS may not look as dehydrated as they are because the hypertonicity lead to the preservation of intravascular volume, causing movement of the water from intracellular to extracellular space. Now, regarding biochemical changes, HHS should not be diagnosed using biochemical parameters alone. However, the blood glucose is markedly raised, that is more than or equal to 30 mmol per liter, as is the osmolality more than or equal to 320 mmosmol per kg. Osmolality is useful as an indicator of severity or for monitoring the rate of change with the treatment. Serum osmolality is often provided in biochemistry report, either calculated or measured, but can be calculated using the formula, that is 2 into sodium plus glucose plus urea. Now regarding changes in the cognitive performance during HHS. HHS can have marked effect on the cerebral function and be associated with the transient changes in the cognitive performance and also with the long-term effect. This may be due to number of things, including but not limited to cerebral edema in severe cases, but the presence of significant electrolyte disturbances, acute changes in the osmolality, dehydration, infection or sepsis, hypoglycemia during treatment, or kidney injury. Daily assessment of cognition during admission with comparison to the pre-morbid state should accompany full history, physical examination, and review of drug therapy on admission. Now, goals of the treatment of the HHS. The goals of treatment of HHS are to address the underlying causes and to gradually and safely. So, first one is normalizing the osmolality, then replace the fluid and electrolyte losses, and then normalize the blood glucose. So the goal include prevention of arterial or venous thrombosis and other potential complications like cerebral edema, central pontine myelinosis, osmotic demyelination syndrome, and foot ulceration. So care for people with HHS can be complex and they often have multiple comorbidities and may require intensive monitoring. The presence of one or more of the following should prompt discussion because they indicate the need for admission. Immediate senior review by clinicians skilled in the management of HHS should be considered. So measured or calculated osmolality more than 350 mmosmol per kg, sodium more than 160, my venous and arterial pH of 6 on admission. Then GCS Glasgow Coma scale and acute kidney injury, hypothermia, then microvascular events such as myocardial infarction or stroke, and other serious comorbidities. If any of these if any of this is present, then we should seek the help of the specialty. Now, regarding the type of the fluid, the goal of initial therapy is expansion of the intravascular and extravascular volume and to restore peripheral perfusion. However, Cochrane review recommended the use of crystalloid fluids rather than the colloid in critically ill individual because the use of crystalloid is associated with less need for further intervention. As majority of electrolyte losses are sodium, chloride, and potassium, the initial fluid replacement of choice should be 0.9% sodium chloride solution with potassium added as required. Regarding osmolarity, sodium and glucose, the key parameter in the HHS that need to be taken into account is osmolarity. Sodium and glucose are main contributor to this, and too rapid changes are dangerous because large fluid shift can lead to neurological complication, in particular cerebral edema, then cerebral pontine myelination and osmotic demyelination. So osmolarity can be calculated using the formula like 2 into sodium plus glucose plus urea. Use of the previous version of this guideline has confirmed that fluid replacement alone with low glucose concentration. The fixed rate insulin infusion should not be started as a part of initial treatment unless the significant ketonemia is present, that is more than 3 mol per liter, or urine ketones are more than 2. In all circumstances, intravenous fluid should be administered first, and then fixed rate insulin infusion only started once glucose had stopped falling. The risk of adding insulin at the start of treatment is that this will lead to large osmotic shift leading to neurological complications. In addition, adding IV insulin too early will also potentially lead to circulatory collapse. If IV fluid and fixed rate insulin infusion are managed appropriately, the fall in measured or calculated serum osmolarity should be within target range of 3 to 8 mmol per kg per hour. If the rate is faster than this, it increases the risk of neurological complication such as cerebral edema, cerebral pontine myelination, and osmotic demyelination. Now regarding potassium. People with HHS are usually potassium depleted due to potassium, but potassium shift are less pronounced than those with decay because they are less acidotic. The difference driven largely by the lack of insulin in decay. In addition, the fixed rate insulin infusion rate is lower and there is often coexisting renal impairment. However, hyperkalemia can be present with acute kidney injury. In addition, those on diuretic may be profoundly hypokalemic. Potassium should be replaced or omitted as required. A suggested potassium replacement regimen. If it is more than 5.5, then no potassium replacement is not needed. If it is potassium between 3.5 to 5.5, then 40. If it is below 4.5 for 3.5, then senior review as additional potassium is required. Or we can replace it via central line in ICU. Now regarding isotonic versus hypotonic fluid replacement. Rapid changes in the osmolarity may be harmful. 0.9% sodium chloride solution should be used as the principal fluid to restore circulating volume and reverse dehydration because it is relatively hypotonic compared to serum in someone with HHS. Measurement or calculation of osmolarity should be undertaken every hour initially and rate of fluid replacement adjusted to ensure positive fluid balance sufficient to promote gradual decline in osmolarity. Fluid replacement alone will lower the glucose concentration, which will lower or calculated serum osmolarity by causing a shift of water into intracellular space. This inevitably results in rise in serum sodium. A fall in blood glucose of 5.5 mmol will result in 2.4 mmol rise in sodium. This is not necessarily an indication to give hypotonic solution. A rising sodium is only concern if osmolarity is not declining concurrently. If the inevitable rise in serum sodium is much greater than 2.4 mmol per liter for each 5.5 mmol per liter fall in blood glucose, this would suggest insufficient fluid replacement. The rate of fall in serum sodium should not exceed 10 mmol per liter in 24 hours. A safe rate of fall of plasma glucose is between 4 to 6 mmol per hour. The aim of treatment should be to replace approximately 50% of estimated fluid loss within 12 hours and the remainder in following 12 hours. However, this will in part be determined by initial severity, degree of renal impairment, and comorbidities such as heart failure, which may limit the speed of correction. An initial target glucose between 10 to 15 mol per liter is reasonable goal until the person is eating, drinking normally, and then individual target glucose, if appropriate, 6 to 10 mol per liter should be set by diabetes specialist team and the person with the diabetes. Complete normalization of the electrolytes and osmolality may take up to 72 hours. Now, hypotonic fluid replacement. Ideally, the people will recover quickly enough to replace the water deficit themselves by taking fluid overload. However, if the osmolarity is no longer declining, despite adequate fluid replacement with zero point 0.9 sodium chloride solution and adequate rate of fall of plasma glucose is not being achieved, then zero point 0.4 sodium chloride solution should be substituted. There are no data to justify using the fluid that are less hypotonic than the 0.45 sodium chloride solution. Now regarding insulin dose and time. If significant ketonemia is not present, do not start intravenous insulin infusion. Only commence insulin infusion quickly in following circumstances. If there is Hhs and the ketonemia, that is blood ketone level, blood ketones are more ketone, that is 3 beta hydroxybutyrate more than 1 and less than 3, and urine ketones are less than 2, and there is no acidosis, that is venous pH is less more than 7.3 and bicarbonates are more than 50, then use 0.05 units per kg per hour. Or if there is significant ketonemia, that is 3 beta hydroxybutyrate more than 3, or ketonuria, that is more than 2 plus with acidosis. Then we can start with the insulin infusion. Fluid replacement alone with 0.9% sodium chloride solution will result in falling blood glucose, and because most patients with Hhs are insulin sensitive, there is a risk of lowering osmolality precipitously. To prevent the measured and calculated serum osmolality falling too quickly, the plasma glucose ideally fall by no more than 5 mol per liter per hour. Insulin treatment prior to adequate fluid replacement may lead to cardiovascular collapse because water will move out of the intravascular space, resulting into the reduction in intravascular volume. So the recommended insulin dose is a fixed rate insulin infusion given at 0.05 unit per kg per hour. A fall of glucose at the rate up to 5 mol per liter per hour is ideal. Once the glucose has ceased to fall following initial fluid resuscitation, then reassessment of the fluid intake and the evaluation of the renal function must be undertaken. Insulin may be started at this point, or if already in place, infusion rate increased by 1 unit per hour. As with decay, the fixed rate insulin infusion is preferred, though generally lower doses are required. Clinical scenario and interpretation of serum sodium, osmolality, and glucose concentration. If serum sodium is increased but osmolality is declining at appropriate rate, continue 0.9% sodium chloride solution. If serum sodium is increasing and the osmolality is increasing, check the fluid balance. If it is inadequate, increase the infusion rate of 0.9% sodium chloride solution. If osmolality is increasing and the fluid balance is adequate, consider switching to 0.45 sodium chloride solution given at same rate. If osmolality is falling at the rate exceeding 8 smol per kg per hour, then consider reducing the infusion rate of IV fluid and insulin. If blood glucose is falling at less than 5 mol per liter per hour, then check fluid balance. If fluid balance is inadequate, then increase the rate of infusion of 0.9% sodium chloride solution. If fluid balance is adequate, then commence and fixed rate insulin infusion at 0.05 unit per kg per hour, or if already running, increase the rate to zero point 0.1 unit per kg per hour. If the blood glucose is falling at over 5 mol per liter per hour, then check the rate of change in osmolality and consider reducing the rate of fluid replacement and or intravenous insulin infusion rate. Regarding antibiotic therapy, as with the all acutely ill patients, sepsis may not be accompanied by pyrexia. An infective source should be sought on clinical history and examination. Antibiotics should be given when there is a clinical sign, laboratory, and radiological evidence of infection. Now, regarding anticoagulation, having diabetes is associated with increased risk of developing venous thromboembolic disease. Patients with HHS have increased risk of arterial and venous thromboembolism. A study of hyperglycemia during COVID-19 admission suggested that risk of arterial and venous thromboembolism was 3 times higher than those without hyperglycemia. Other work has estimated that patients with diabetes and hyperosmolarity have the risk of venous thromboembolism similar and only marginally above those with acute renal failure, acute sepsis, and other connective tissue disease. The risk of venous thromboembolism is greater than in non-diabetic ketoacidosis. Other factors such as hypernatremia, increased vasopressin concentration can promote thrombogenesis by producing changes in hemostatic function consistent with hypercoagulable state. Everyone with HHS should receive prophylactic low molecular weight heparin for full duration of admission unless contraindicated. There are no data recommended that this advice be extended to the therapeutic anticoagulation. Full therapeutic anticoagulation should only be considered in those with suspected thrombosis or acute coronary syndrome. Other electrolyte imbalance and complication associated with HHS. Hypophosphatemia and hypomagnesemia are common in HHS. There are no data looking at the use of replacement of either of these HHS. If low concentration persists beyond the acute phase of treatment and the patient is apparently symptomatic with good risk factor for long-term magnesium deficiency, oral replacement must be considered. Proton pump inhibitor is common in some population who develop HHS, and the use of this drug has been associated with hypomagnesemia. Regarding food production, people with HHS, they are at high risk of pressure-related food ulceration. An initial food assessment should be undertaken on admission and daily during admission. Heel protector and appropriate mattress should be provided for those with immobility, neuropathy, peripheral vascular disease, or lower limb deformity. If individuals are too confused or sleepy to cooperate with assessment of sensation, assume they are at high risk. Now, definition of resolution of HHS. The serum osmolality should be less than 300. Hypovolemia has been corrected. Cognitive status has come to a pre-morbid state, and blood glucose are less than 15 mol per liter. Now, regarding this, when and how to start fixed rate intravenous insulin infusion in HHS. So, if ketones are less than 3 and if it is not acidotic, that means if the blood pH is more than 7.3 and bicarb are more than 15, then what we should do? In this case scenario, do not start fixed rate insulin infusion immediately. Continue to monitor hourly capillary glucose during IV fluid replacement. Use the lab venous glucose if capillary reading is more than 28 mol per liter. Once the glucose plateau with fluid replacement alone, then commence the fixed rate insulin infusion at the rate of zero point 0.5 unit per kg per hour, aiming the target glucose of 10 to 15 mol per liter. Now, in case of HHS, the blood ketones are more than 1 and the urine ketones are more than 2. And if they are not acidotic, then start the fixed rate of insulin infusion immediately at the rate of zero point zero 0.5 units per kg per hour. Continue to monitor hourly capillary glucose during IV fluid replacement. Then continue to monitor capillary ketone hourly. If glucose is dropping too quickly, then reduce the fixed rate insulin infusion rate by 50%. Then repeat the glucose and blood ketone hourly. If necessary, adjust the insulin infusion rate to ensure the ketones are clearing and and glucose is falling in controlled manner. Aim for target glucose of 10 to 15 mol per liter. Now regarding significant hypovolemia, hyperosmolarity and pH is less than 7.3 and ketones are more than 3. This suggests the mixed picture of HHS and decay. In these circumstances, the decay pathway should be followed. Commence the IV fluid and the fixed rate insulin infusion of zero point 0.1 unit per zero point 0.1 units per kg per hour. Thank you.